I was asked to talk on distal tibial plating, what went wrong. And in all honesty, this makes up a huge part of my practice. And one of the great papers written on it, actually, was done by someone on the panel here, Don, back in the 80s, showing that the AO technique, as great as it was, the AO group was operating on skiing injuries. We were in America taking that and extending it to high energy injuries. And Don was the first to write a large series on that, showing the problems the soft tissue encountered with big open incisions of the distal tibia. My disclosures, I'm going to show you two such problems, because this is probably one of the major things I see, and it's very difficult. Here's a 23-year-old healthy guy, FedEx delivery truck driver. He swerved to avoid another car and kind of started making a turn, and literally it was like a Bugs Bunny cartoon where he's holding onto the steering wheel and he's sideways with both legs out the door of the FedEx truck, and it rolled on his leg. And there was maybe small open wounds on his leg, but it was mainly a kind of a crush injury. And it was at most pinpoint opens, and treated at a very good center. And he had this pilon fracture, looked like this. This was when he was taken to the OR for initial spanning fixation, but a real crush injury, high energy injury. This is the CT at that time. No hidden agenda. The doc, who's a well-trained trauma orthopedist, did everything appropriate, spanned it, waited, fixed the fibula at 2 weeks, thought she could. Here's the CT following fixing the fibula. She waited 5 weeks to do the formal ORIF. Here it is. Any critiques from the panel?
One of the big decision points is where you put the plate. Do you go lateral or medial? And I always look at the injury film and see what the displacement was. So if it's a valgus fracture, then I want a lateral buttress. If it's a varus fracture, I do a medial buttress. But the only thing that bothers me here is that displaced bone medially that could push on the soft tissues. But otherwise, I think it looks reasonable. You can see some small plates for fixation, and the joint surface looks reasonably aligned and well reduced.
I see a rash of small plates now, and I'm still trying to figure it out. Mixed feelings, I guess.
Think on the small plates, you have to decide, are they really designed for, as a reduction technique? So you've got some key pieces that you want to put on a little 2-0 plate, and then it just helps you. And then after you've got your definitive fixation, do you leave them in, or do you take out the little mini plates?
And what I wonder is, those plates are in the part of the bone that we're kind of taught to ignore anyway. So why do you need to be there, I guess, is a question.
What little mini plates show me is where stuff was stripped. I hate to say it, but now here's the soft tissue envelope. Ooh. Yeah. So we know where this is going, right? The tibia was taken out. It's a one vessel leg, which doesn't frighten us for a flap. 50% of the flaps, the lower extremity, we end up doing are on one vessel legs. It's just gotta know it. But opened up, broke down. She decided to put beads in it and transferred it. It was dead bone all over. And there was where this is gonna go. She had dead bone for a segment like that, and you'll know the rest of the story then. But a problem, and even waiting 5 weeks sometimes isn't enough. It's the soft tissue that will burn you here. A huge part of my practice is because of soft tissue problems that have to be reconstructed. Here's a more recent one, a 51-year-old male, ATV rollover. Closed right femoral shaft fracture, treated with a retrograde nail. Closed right tibia fracture. It was either a day or two after this. It was a crush injury. He was treated with ORIF by a doc fresh out of his fellowship from shock trauma, maybe 4 months out of training. Well trained, good doc. 2 weeks later, things started looking bad. up where he was, they decided there was a problem, and we're seeing more and more of this lately, where patients are having a wallet biopsy, and if they pass, they find microsurgeons at that institute who suddenly can throw a flap on, and if they fail the wallet biopsy, they get transferred. But we do a lot of flaps after failed flaps. I counted, it's about 27% of the patients we see that need a flap have had a failed flap before, be it rotational or free. This person had a free gracilis that failed rather quickly, then we're called and said, hey, just throw another flap on it and send him back up and we'll take care of it. Here he is, and this is my new record for number of plates inside a leg. I count 7. And I think putting every little piece back together sometimes doesn't always, although it makes for a beautiful x-ray, I think it can cause some problems, and in some ways maybe we're going backwards a little, and it worries me. So he got sent to us, and actually, if you look up close, you could literally see the biofilm on that plate, the slime. It was a problem, and unfortunately, when it's like that, there's usually some dead bone coming along with it for the ride. There you can kind of see the slime. It's real. He had to get it took us cutting back to there just to get healthy bleeding bone on both sides. So I think the problem is we're going backwards sometimes in little ways, and the most important thing to me on all these fractures is not looking at the bone, it's the soft tissue. And you lose that envelope, you know where this thing's going to go. It's not going to end well. And it requires more fancy things, such as this person required. And he got transported and did well, but I think it's worth a discussion point in that we really have to protect the soft tissues and do what we can. And if that's your only thing you focus on at first, you're going to be ahead of the game no matter what.